good evening, and thank you for joining us here on BlackDoctor.org. I am Ellis Dean, the Director of Digital Programming and Production at BlackDoctor.org, and we have a wonderful program scheduled for you this evening. This is our monthly series called Seeing Eye to Eye, and it is brought to you in partnership with the Children's Vision Equity Alliance, the National Eye Institute, and everybody over there. They have been wonderful, wonderful partners. And we started this last year. Man, we're coming up on our year anniversary of these programs. And we've talked about glaucoma and all types of ID, low vision, eye damage, all types of stuff. So this month is we're going to pivot just a little bit. And we're going to talk about sickle cell disease, right? And we say, well, how does sickle cell relate to vision? Well, that's what you're going to find out tonight. So we're going to talk about that with our two wonderful guests. But before we introduce them, got a couple things I need for you to do. Number one, let us know where you're watching from. We always like to know where people are watching us from all over the nation, all over the world. So please drop that in the comment section and we'll give you a shout out. Number two, share this, like this program, share it. Tag a friend, anybody that needs this information. We want to get this out to as many people as possible. And it starts with you, and you are our partners in that. So please do that. And number three, if you have any questions, also please put that in the comment section below on your page. So, and if we have time, if time permits, we can get those questions asked and answered, because this program is all about you and getting you the information that you need. All right. I've gone through all the particulars. Let's get to who these guests are. First up, we have Dr. Adrienne Scott. She is Associate Professor of Ophthalmology at Wilmer Institute and Johns Hopkins University. You know, that's a prestigious university. So welcome, Dr. Scott. And also we have Dr. Andrew Campbell. He is a hematologist and Director of Comprehensive Sickle Cell Diseases Program at Children's National Hospital in Washington, D.C. So you know that, especially he's in the nation's capital there. And he's a hematologist, and we need more hematologists, particularly for the disease state we're going to discuss tonight. So thank you both for joining us, and welcome to tonight's program.
Thank you very much, Alice. Pleasure to be here.
Great.
Pleasure to be here. Thank you so much.
So Dr. Campbell, we'll start with you. What is sickle cell disease? And also in that explanation, could you tell us the difference between having sickle cell trait and the actual disease? And how do you get it, right? How does someone get sickle cell disease? And what percentage of Black people have the trait, not the disease? I know it's a lot. It's three-parter, so let me know if you need to know anything else about that question.
Oh, these are all excellent questions. I'll first start by just talking about sickle cell disease just in general, okay? I think it's important to start with that because many people are aware of sickle cell disease in general and may have known someone with it. So essentially, it is a group of blood disorders that affects what's called hemoglobin, and that carries oxygen throughout the body. It affects over 100,000 individuals in the United States, primarily African Americans, but can affect anyone throughout the world. But it affects approximately 20 million individuals throughout the world. Now, the sickle cell itself, it's actually shaped. The normal red blood cell is shaped like an oval round shape, but the sickle cell is shaped like a quarter moon shape or crescent shape, right? Almost like a C, if you will. And that is the shape that many patients with sickle cell disease, which we'll talk about disease and trait, have, and that can cause damage in the blood vessels, okay? And that can lead to lifelong, starting in infancy, pain and organ damage, okay? And this C shape or crescent moon shape red blood cell causes pain, which is the most common hallmark of sickle cell disease, and it causes pain in the bones and causes episodic pain, and it is the most common symptom that we see in sickle cell disease patients. Now, how do we separate sickle cell disease patients versus sickle cell trait patients? Now, it's a little bit of kind of an alphabet soup, if you will, genetics. So, someone with trait, um, they're a carrier for the gene, right? So they have one normal gene, let's say A, and the other gene is the sickle gene, J, A and S. A patient, sickle cell disease patient carries an S and an S gene, right? So they don't have the normal A gene. So if you have an S and an S gene, and you inherit each one of these genes from a parent, okay? So if you have an S and an S, that means your mother or and your father are at least carriers of the sickle cell gene, and that is something that we see a lot, right? The second part of this is the S gene. The S gene can also combine with other hemoglobins, which won't go into too much detail. It can cause other forms of sickle cell called SC sickle cell disease, or another condition called sickle beta thalassemia. So really the bottom line is sickle cell trait is essentially a carrier status. You don't have the symptoms of pain. You don't have a lot of complications, versus the patients with both genes, the S and the S, can have symptoms of sickle cell disease. And again, pain is the most common symptom, but they can also have in-organ damage. You can have damage over time to your kidneys, your lungs, uh, and Dr. Adrian Scott will talk about also to the eyes. That's that's the overall description of sickle cell trait versus sickle cell disease.
Okay, so it sounds like more people have the trait than actually have the disease, because that has to be
Correct.
kind of like, that's got to be like a perfect alignment, almost a perfect storm, for lack of a better term, in order to develop sickle cell disease. But
Right.
you can have the trait, and having the trait, you could have some of the disease-like symptoms. Is that true?
Yeah, sickle cell trait you can. So this will back up a little bit. One thing I just want to mention, um, sickle cell disease happens in approximately 1 out of 365 African American births primarily. And then sickle cell trait, there's 1 to 2 million individuals with sickle cell trait, primarily African American, in the United States. Okay.
Okay.
So it's about 8 to 10% of African Americans are carriers of the sickle cell gene, meaning that they have trait. So it is more common, as you talked about, Alice. Now, you were talking about earlier, can you have complications from trait? Yes, it is rare. Okay. What are those symptoms? So in sickle cell trait, you can have, in rare circumstances, you can have effects at things that it can affect your kidneys, for example. In a very small percentage of patients, they can have, we call it blood in the urine. The medical term is called hematuria. It is a painless urination of blood in the urine. However, with that, that's because the sickle cell trait in that patient has damage to their kidneys from the sickle cell trait, but majority of patients it doesn't affect. The other conditions where you can have problems, other organs that can be problems are the spleen. So if you go into high altitudes, like greater than 10,000 feet into the mountains, let's say you go skiing, where the oxygen tension or the amount of oxygen is thinner, that actually can trigger the body to almost mimic like sickle cell disease. And what it can cause is lack of blood supply in the spleen, for example, which is an organ right under your left rib cage, and that can cause pain in the kind of the abdomen area, and that can cause an area of the spleen to lack blood supply. So you can get damage to the spleen, you can get damage to the kidneys. Now let Dr. Scott talk about the risk of eye problems with sickle cell trait. So I would stop there. But those are the major ones. And in very, very, very rare circumstances, I mean, less than 0.001%, there's a condition called renal medullary carcinoma, where there's a particular type of cancer that has a particular predominance in patients who have sickle cell trait, but it's extremely, extremely rare.
Okay, well that is good to know.
Yes.
So what kinds of people are most affected, and
Yes.
who gets the disease?
Yeah. So individuals most affected primarily, we think, and this is something that now learning about sickle cell disease over the years, are people whose their original backgrounds is essentially associated with the malaria belts of the world. So where there is malaria, so common areas of the world where malaria is common is sub-Saharan Africa, right? People of African descent, obviously through the slave trade, many years ago, hundreds of years ago, sickle cell trait um, actually maps around the world where there is malaria. Another area in the world that it happens is Southeast Asia, actually in India. There's actually millions of patients in the country of India with sickle cell disease. Also in the Middle East, Saudi Arabia, for example, have hundreds of thousands of patients with sickle cell disease. And then also another area of the country, of the world that we see it, is also part of the African diaspora that includes the Caribbean, Jamaica, Haiti, Barbados, all of the Caribbean, and also in South America. We see patients from the most common one is like Guyana, but also we see patients from Brazil, for example. And another area, Central America, there's a lot of patients, for example, El Salvador. In the DC area, we have El Salvadorian sickle cell disease patients. So we think about it from the African diaspora, those are African descent, but also where there's also areas of malaria, because we believe that the sickle cell trait being a carrier for sickle cell disease, being a carrier for the sickle cell gene, had some protection against uh, the more protection against severe complications from malaria. It had protection from you not protecting you from you not dying from from malaria. So it protected you from dying from malaria, getting malaria, and we think this is why the sickle cell gene, the carrier state of it, having one gene, kind of arose. And doing some specific genetic studies done by a group, Dr. Charles Rotimi, they think that the first sickle cell trait actually um, was approximately 7,000 years ago in the country of where Cameroon is in sub-Saharan Africa. So,
Wow. Okay. Well, I just learned something right there, because I always just thought it was only people of African descent, but it seems like that's a big portion of the sickle cell population, but also where there's high areas of malaria. So that's going to be areas probably in humid climates near the equator,
later.
a lot of rainforest kind of situation where they could develop mosquitoes, which is a big transporter of malaria. All right. All right. So we're learning here today, people. Sorry, just stick with us. So last question for you, Dr. Campbell. Then Dr. Scott, you're gonna be on the hot seat. Um, how was sickle cell diagnosed? And I noticed at one point, I've learned at one point they weren't screening at birth, but is there some sort of screening process now where you can kind of know if you're a carrier at birth?
That's correct. So the screening process right now is called newborn screening. Every child born in the United States, you can be born in Montana, uh, Alaska, Idaho to Georgia. Every newborn is screened with a certain set of newborn tests. And sickle cell disease is one of those. They test for the sickle cell gene. They test if you're a carrier, right? That's called sickle cell trait. They test if you have sickle cell disease, right? They also test for other forms of other normal hemoglobins that can also cause sickle cell. So they screen for C, they screen for thalassemia. So if you have those other conditions, you can many times you can pick that up at birth. Now, what this actually rolled out. Um, in 1987, newborn screening was rolled out in a majority of urban areas in the United States, where the higher concentrations of African Americans in the United States. But it was not until, believe it or not, 2006 that it was absolutely mandated that every um, state in the United States did universal newborn training, regardless of race, regardless of background, regardless of skin color, any of it. So it was not until 2006 it was actually officially rolled out of each state. But it's been, most large cities since 1980s, early 1990s. It was really a routine test that was done. And it's a blood test that's done usually within 3 to 4 days of life. It's actually, they take a heel prick. They take a little bit of blood from the heel of a baby, and they put it on what's called tissue paper, like similar to like a tissue, but
Mhm.
like a towel. And they take that spot, we call a blood spot, and that blood spot is taken to the state lab in your state, in the Department of Health in your state, and then they test that blood to see if you have sickle cell trait or disease, or if you have it at all.
So I would add, and you can correct me if I'm wrong on this, Dr. Campbell. If you are dating, engaged, newly married, and you're talking about having a family, and you do not know your status, go get that test done. Not that it should deter you from having children, but that information is good to know, because if you're both trait carriers, that does increase the possibility. It's not 100% that your child will develop sickle cell disease, but it does increase the possibility. So you just kind of want to know heading into that situation.
Yes.
All right, Dr. Scott, you're up. Let's talk about sickle cell disease in the eyes. So the easiest question is, how does sickle cell disease affect the eyes?
Thanks for the question. Yeah, it's similar to what Dr. Campbell was describing, that sickle cell affects the blood cells in every organ that requires a high blood supply. So that includes the brain, the kidney, the lungs, your feet, your arms, your fingers, etc. Also, similarly, the eyes are affected. So almost every organ system can be affected, the bones. But the eyes particularly are vulnerable because the retina is the nerve tissue. It's the back lining of the eye. If you imagine the eye as a camera, you think about the retina as the film in the camera. So it requires the retina in order to help you see well. It senses light, brings light back to the brain, helps you see. So it requires a high oxygen flow from a lot of blood vessels. So it's very unique in the situation where we can dilate the person's eyes and we can actually see blood flow from the eyes. And in some cases, we can see where there's abnormal blood flow from the hemoglobin molecules we talked about that carries the abnormal oxygenation carrying ability there. So it can affect the eyes in several ways, but the most common way that sickle cell retinopathy does cause vision loss is affecting blood flow within the retina.
Wow. Okay. So do children are children impacted by this, or is that something that develops over time?
Yeah, great question, Alice. I think it's good to know for anyone listening that most people with sickle cell disease actually have good vision. So, we'll talk a lot about complications that can result from abnormal blood flow in the circulation of the eyes, particularly the retina. But the good news is most people with sickle cell disease do have good vision and have a good prognosis for vision. But because it is a genetic mutation that, as Dr. Campbell spoke about, is present from birth, the damage that the abnormal hemoglobin causes to the circulation is happening, from the moment you are born. And children can have, and even we do sometimes see children with affected circulation in the retinas, even at a very young age, because of sickle cell disease. So it can affect children as early as It's reportable, but it's very, very rare. But even in some newborns, it's been reported to have retina changes. But most commonly, when I'm seeing kids in my clinic, when they're able to sit for the exam about age, 4 or 5 is probably the youngest child that I have in my clinic that can sit for the type of dilated eye exam that I do. You can even sometimes see very small, minor ways that the blood flow has been affected by sickle cell disease, even if it's not visually significant.
Okay, so I tell people all the time, I interview doctors on a regular basis, so I know enough to be dangerous. So we did a series with Dr. Joe Coney on diabetic retinopathy. And it's my suspicion that diabetes and sickle cell would be a rough combination on the eyes. Is that?
Yeah, that's a really interesting question, Alice. We don't know exactly how the two combine together. They do cause some similar type of uh, damage from lack of blood flow. Patients with diabetes can get decreased blood flow that can cause abnormal oxygenation. There can be abnormal blood vessels forming, and the situation is similar in patients with sickle cell disease. We're actually currently doing a study sponsored by the American Academy of Ophthalmology to be able to look at patients in a large database to see, well, what happens when you have sickle cell disease and diabetes? What is the effect on the eye? So that's a really timely question that you ask.
Well, good. Hey, look, I'm cutting edge research.
You're on it.
Okay, so you did a good job of kind of describing this, but I just want to make sure that the people. So if I have sickle cell disease, does that mean I'm going to lose my vision? I have a chance of losing my vision, or what impact? Is it like 50% chance I can lose my vision? What's the ratio in terms of vision loss when somebody with sickle cell disease?
The prognosis overall in most types of sickle cell diseases is very, very good. But many of us, as mentioned by Dr. Campbell very, very astutely, obviously that it's so common in our Black population that we know somebody who's got sickle cell disease, or we know somebody who's affected with the trait. And it's very heterogeneous, meaning that you can have people with a similar mutation in the sickle cell or in the hemoglobin molecule and have a completely different set of problems. So you can have some people that have this mutation and they don't have pain and they don't have vision problems and they very rarely ever have to go to the doctor. And that's amazing. And then you have some people that have the exact same mutation that are very ill from the sickle cell disease. They have to go to the doctor frequently. They have pain all the time, and have these other complications we talked about: the bone, the kidney, the brain, risk of stroke, retinopathy, retinal damage. So it's a very diverse disease as far as the same mutation can affect people very differently. So the bottom line is, I don't think anyone with sickle cell disease or trait should think that they're automatically going to lose their vision, but it's very important to be screened and be followed if you have sickle cell disease, because we can pick up early blood vessel damage, or we can comment more with a good dilated retinal exam on what the actual risk is. There are specific types of genes, and Dr. Campbell mentioned briefly, that predispose slightly more to developing retinopathy risk throughout your lifetime. So knowing the type of mutation or abnormal hemoglobin that you have, or that your family member has, or that your child has, is really important and will help determine what their overall risk is of these different complications.
So if you're just joining us, we are on our monthly Seeing Eye to Eye program here in partnership with the Children's Vision and Equity Alliance. And we are talking to Dr. Andrew Campbell, who is a hematologist at Children's Hospital in DC. And we're talking to Dr. Adrian Scott, who is an ophthalmologist who is working at 2 universities, prestigious universities. And apparently she's working on some great studies as well to kind of really determine sickle cell and eye disease, and eye loss and vision loss. And so we are really happy to have them here. I got a quick question. So if you're just joining us, also let us know in the comments if you know someone that has sickle cell disease. I just want to do a quick poll of everybody. So just put a yes or no, thumbs up, whatever you want to do. Drop that in the comment section. Let us know if you know someone that has sickle cell disease? Because we kind of want to, because yes, I think the estimates that I've been reading about says there's about 100,000 or so sickle cell patients in the United States. And we also know that the Black community is about 3 degrees of separation between all Black folks. I'm not in the full 6, but it's about 3 between if you know somebody that knows somebody that knows somebody. And so I see some comments starting to come in here now. So thank you for answering that. So yeah, just let us know if you know somebody that has sickle cell disease. Oh yeah, somebody says, I got a thumbs up from Betty. Thank you, Betty. Francesca says, yes, her father, brother, and sister all have sickle cell disease. So that is, thank you for sharing that, and keep those answers coming in. So why do different genetic mutations of sickle cell disease, as you were talking about, have different risk of retinopathy? That just, that seems like so unfair, right? It's like you want to be able to have one lane, one treatment, but if we've got all these mutations and it has different impacts, that makes it harder on you as a treating physician, and it also makes it harder on the patient because it's going to be more difficult for them to find a solution that's going to work. It's got to be really tailored to them and how it mutates in their body.
Yeah. So great question. So why do different genotypes or genes of sickle cell have different sorts of complications that we have to watch out for? As mentioned earlier, it's such a varied disease with how it affects how someone is ill from it. So there's a particular genotype called SC, where you have 2 abnormal copies of hemoglobin, one from mom, one from dad, as stated by Dr. Campbell. And those individuals have a higher risk of developing retinal problems and vision loss in their lifetime from retinal damage. And it's really, again, important to know what type of gene the individual has to be able to determine their overall risk. The interesting thing, and why this disease is so fascinating to study, is that the individuals who have the highest risk of retinopathy, patients with the SC variant that we talked about, may not ever have any systemic symptoms or very little. They may not have pain that, often brings them to the ER. They might, but they might not. And I've even seen patients present, in adulthood with vision loss. And then you ask and you say, well, do you have any, history, or do you have sickle cell disease? And they may not even know it. So it may not have even manifested or shown itself until the person unfortunately has eye disease. As Dr. Campbell was mentioning, these newborn screening tools were, relatively recent. So if we're seeing, if that became standard in 06, 07, for babies in 50 states, think about, most of us adults walking around or born in the 70s, 80s, 60s, 50s, whatever have you, we may not have benefited from this. So those individuals may not even know they have an abnormal hemoglobin until sometimes it can manifest as vision loss.
Dr. Campbell, real quick, because we've done a number of programs on sickle cell, and one of the things that we find common is they call it a pain, kind of an incident, right, where they have to present to the emergency room because they're in excruciating pain. Is there something that a person that is living with sickle cell disease can do to reduce those types of incidents, to reduce the number of times they have to go to the emergency room? I'm also been learning that sickle cell patients have to get a lot of transfusions.
Yeah.
So is there something that they can be doing to reduce those incidents?
Yeah, there's a number of things. I think some of it has to do with the type of sickle cell they have, but let's start with the broad. Yeah, so sickle cell can have, what we don't understand is some patients have mild pain, a few they have mild pain, some have severe pain, some have a few episodes, others may have a lot of episodes. So depending on where you fit with sickle cell disease, kind of determines how you prevent, right? But overall, there is, for example, let's talk about medications. There's an FDA-approved drug for children 2 and older and all adults called hydroxyurea. This is a well-known medication that has shown to decrease painful events by 50% at least. Um, and it's been shown to be effective. The majority of patients tolerate it. Okay, you have to take it every day. What it does, it cools the inflammation down that's associated with sickle cell disease, but also it actually makes a different. It tells your bone marrow to make a different type of hemoglobin called we call hemoglobin F or fetal hemoglobin, which is our baby hemoglobin. We were all born with like 89, like 99% baby hemoglobin called fetal hemoglobin. What hydroxyurea does is it tells the bone marrow to make less of sickle and make more of this baby fetal hemoglobin. So in
Mhm.
essence, you have less sickle. So if you have less sickle cell around, you have less pain crisis.
Right.
That's one. Number two, um, the simple things such as rest, making sure you have enough sleep, um, drinking lots of fluids. So fluids, drinking lots of fluids are very important. Keeping your body well hydrated because we know in a state of dehydration, if it's too hot outside, you drink lots of fluids, right? If you're sick, you have a cold, you tend to be more dehydrated more, right? So in those conditions, it's too hot, or you have an illness, drink lots of fluids. It keeps the vessels more flushed, less making it less likely for sickle cells to kind of stick to the vessel wall and cause pain crisis. So you want to make sure you're drinking lots of fluids. Um, the other is just making sure that you're taking care of yourself. You're resting, right? Um, you are things like not smoking, for example, and getting a restful night of sleep. These are all important. Also, a little bit of exercise is good. And a lot of times with sickle cell, they say don't exercise. When I was training, there was anti-exercise,
Mm.
or because it can trigger pain crisis. But now what we're saying is cardiovascular health. We talk about that is good for everybody, even for patients with sickle cell. So staying active to the degree that you can actually tolerate, right? That's safe. So staying half active, similarly to someone without sickle cell disease. Now, the last thing I would say is triggers. Avoid trigger situations. There are triggers. So if you talk to sickle cell, there are situations where they can trigger a pain crisis. So, for example, if it's very cold outside, right?
Mm.
You want to make sure you wear layers of clothes because if you're not, if your skin, your bones are exposed to cold for a prolonged period of time, that can cause the vessels in the body to we call vasoconstrict. And if there's sickle cells in there, they're more likely to sickle, right? So making sure if it's cold outside, especially with the windshield, but if it's cold outside, always dress warm, wear a hat, wear socks, and layers when it's cold. Two, um, you want to, yeah, swimming pools. A lot of people forget if it's cold swimming pools, you want to make sure that if you're a sickle cell patient, you want to swim in a pool that's warm. I'm sorry, bath water like 75, 80 degrees, something that's warm. Because if you go into a cold pool, like a lake, for example, in climates where it's cold, or if you can go in the Atlantic Ocean during the spring if it's cold, in some patients that can trigger a pain crisis as well. So you want to avoid those situations. You want to make sure the water is warm. Um, and I think staying vaccinated. I'm just throw that out there. I know we had the COVID vaccine. Not to throw that in there,
That's a
but
bad
just
word.
being
That's a dirty
yeah,
word.
I know, a dirty word, I know, but just in general, vaccinations in general, just preventing infections. I'm going to kind of put that in one bucket, preventing infections, and that's what vaccinations do. It protects infections, and we know infections can cause problems in sickle cell disease. It can lead to pneumonias in certain cases. Getting the flu shot, for example, helps protect you against the flu. So all of these, maybe you might get the cold, you might get a cold, but patients with sickle cell disease might get pneumonia, and that's true, actually, because some of these viruses can cause pneumonia. So we really want to make sure that a healthy style, and also make sure you have you are up to date with your clinic visits with a hematology provider, so that when they get kind of the labs and doing the we call anticipatory guidance, the checks and balances that we do when you come into clinic that can help avoid complications that might be in the near future.
Great. Thank you for that. 'Cause I just think with the people that are watching that have family members that are suffering with, not suffering, are living with sickle cell disease, it's kind of know to have expand that circle so they know what they're dealing with and how they can help their friend or their family member uh, live a healthier life with sickle cell disease. Dr. Scott, we've mentioned the word retinopathy, but we didn't tell people how to check for it. So, how does somebody with sickle cell disease get retinopathy checked for? Is it the same as somebody that's not doesn't have sickle cell? And at what age should that check start?
So, generally speaking, the Eye Institute, National Institutes of Health, recommends screening in patients with sickle cell disease, referral to an ophthalmologist, particularly ideally a retina specialist, somebody who's trained in ophthalmology, a medical doctor who has special expertise in examining the eye, particularly the retina, even at age 10. So age 10, and then every 1 to 2 years thereafter, depending on, if there's any findings or not to be followed. It's very important that this is a dilated exam. So also our pediatric ophthalmology colleagues are on the front lines and fantastic at examining kids who have sickle cell disease to determine whether or not there is retinopathy, which is really just the term that means, any sort of blood vessel changes that affect the retina. So beginning at age 10 is the recommendation. In my clinic, I really like to see the children as early as they'll sit for me for the dilated exam, which is usually age of 4 or 5. I feel like it gets them used to the exam. It's something they need to do their whole life to be monitored. And it gets, the family and everybody in practice of saying, okay, you got to go get your eyes checked and dilated at least once a year by an ophthalmologist. Now, it's very critical. I want to point out that this is a dilated exam. So it's unfortunate sometimes when you see somebody go get checked for glasses, which you can do without having dilated the eyes. And you go to a local, maybe strip mall down the street, and you get glasses checked. And then as a patient, you may think, well, I've had my eyes checked. Doesn't that count? So it only counts if you have a thorough dilated exam, by somebody who's trained in identifying retinal changes. So the ideal, it's okay to go to the local eye care provider for glasses. That's good. That's great. But it's really important to make sure and confirm if you have sickle cell disease, or if you have a family or loved one or child, spouse, partner, whatever have you with sickle cell disease, make sure they're getting a dilated eye exam at least once a year. And your ophthalmologist will be able to tell you, are there sickle cell changes that we see? Is there retinopathy? There's a very well-defined staging system for identifying these abnormal blood vessels, and we can look at the eyes with a dilated exam and be able to give you that information.
That is fantastic. Go ahead, Dr. Campbell. You want to...
Yeah, I was going to answer Dr. Scott. We have our families going to see. A lot of times they're getting their eyes checked for glasses, and they're unaware if their eyes are dilated to look in the back of their eyes. So we specifically ask, um, you know, that we ask the families to ask the eye doctor if they looked at the eye, and did they look at the retina, and did they comment on the retina, and are they trained to do this? Because we will shift their, we will do additional, um, or shift their eye care provider sometimes if their eye care provider they're not looking at the back of that eye. So important, but it's missed so many times in the community. So this is a very important point for provide healthcare hematology providers to ask um, their patients, but more importantly for patients to ask their doctors, what do they look, who should we talk um, to look for an eye provider who can examine the retina. So this is very important.
Yeah.
Absolutely. And with all of these programs programs I've been hearing, and I've learned that you have to go, whether you have sickle cell disease or not, you should go get your eyes dilated once per year uh, by so they can see all the way through, because there's some things that aren't going to get caught by your traditional eye exam, which is screening for glasses and contacts. But still, go do that if you're having some trouble with your vision. But that dilation is something that's very important, and I've learned from all of these productions that we're supposed to get that done on a regular basis, or at least on an annual basis. And then if something is going on, then you may have to get that done more often. So let's talk about treatments and potential cures. So Dr. Scott, let us know, what's the treatment for retinopathy if somebody develops some sort of retinopathy with sickle cell? What does that treatment look like?
So for most patients, it's annual monitoring, and many times we will obtain special images, retinal images of the blood vessel scans, of the retina that can help us follow things over time. And they may not need any treatment. In fact, most people don't. However, the biggest concern we have is if abnormal blood vessels grow. And so if the retina doesn't get enough oxygen, what happens is there is a signal the body sends out to make new blood vessels. And you would think, oh, well, that's a good thing. New blood vessels are good. But these new blood vessels, unfortunately, are bad because they can cause hemorrhage or bleeds into the eye. And those are the patients that get sudden vision loss from hemorrhage into the eye. And these new blood vessels, unfortunately, can not only bleed, but they can turn into scar tissue and pull on the retina. And as we talked about, the retina is very thin. It's thin like tissue paper. And what happens is those new blood vessels pull on it. It can cause a retinal tear or a hole or even a detached retina, which is a sight-threatening condition that would likely need a surgical repair. So we want to try to avoid that. So one of the main focus points of coming to the ophthalmologist annually is to see, do I have these new blood vessels that potentially could worsen? You can have these new blood vessels and not have any symptoms. You can see perfect vision, 20/20 or better even, with your glasses, contacts, etc. But you can have these new blood vessels that can be detected on your dilated eye exam. So that's why it's very critical. And we can diagnose these abnormal new blood vessels with our eye exam. And we have special retinal tests that we look at the circulation and other imaging that helps us diagnose as well. If we see these abnormal new blood vessels, the gold standard treatment that we've been doing since the 70s is good old laser treatment. And it's not the kind of laser that you think about that it corrects your vision or makes it so you don't have to wear glasses. This is the type of laser that we do for the retina to help these abnormal blood vessels to shrink up and stabilize. And it can decrease the risk of progression to these blood vessels bleeding and causing vision loss. So the first line is laser treatment. And we've also been doing some adjunctive treatment. They're actually medicines that we use as injections in the eye. It sounds scary and horrible, but it is actually very well tolerated, and it can work beautifully with decreasing risk of bleeding from these abnormal new blood vessels.
So get that regular treatment, get that regular visit, right? For sickle cell, as early as it was for children, as early as they can tolerate it, but recommended around 10, but you can go earlier as long as they can tolerate the dilation. And then there are treatments if they do start to develop those extra blood vessels, which I think is both a fantastically protective measure of the eye for the body kind of develops, but also can become problematic over time, as Dr. Scott is talking about, because it's your eyes trying to protect itself, but that protection could cause tears and other problems as a result. So getting that regular dilated visit is going to help your ophthalmologist catch problems before they become problematic, if that makes sense. So, Dr. Campbell, what is you mentioned a medication earlier. What are some other treatments for sickle cell disease? And more importantly, Are we close to a cure? Is there some type of cure out there so people don't have to continue to have pain incidents and all that goes with
Yeah,
living with sickle cell?
yeah. So first is an exciting time in sickle cell. There's a lot of medication. There are a lot of therapies that are in the pipeline for sickle cell. Um, and there's over 20 therapies and clinical trials in different stages, um, that is trying to either decrease the painful events that you see in sickle cell disease, improving the anemia with sickle cell disease, and there are, of course, curative trials, which I'll talk about in a minute. I will just say other medications that are FDA approved for sickle cell disease outside of hydroxyurea. There's a medicine called Adacfil or crizanlizumab, is an IV infusion. Patients 16 and older is given once a month to help prevent pain crisis episodes in the future. There's another medication called Indari. This is a antioxidant powder that a patient is given twice a day to help prevent pain crisis. Um, and there's another medicine called Oxbryta or Voxelotor. It's a drug that is taken once a day to improve the anemia of patients. So right now, there are 4 approved drugs for sickle cell disease right now. The curative options are definitely on the horizon. We know that we know there's one uh, main cure of sickle cell disease. That's a bone marrow transplant. That's where you take the bone marrow. That's you find in chicken bones, for example, in the center of the bones, right? That actually is where the source of red blood cells come from, and those you can actually get a bone marrow transplant from a sibling if there is a bone marrow match. I won't go into details, but if you are a match, um, when they do blood tests, very commonly we'll do a sibling bone marrow transplant. You see this commonly done in pediatric patients, and that can lead to a cure of sickle cell disease, and their sickle cell disease is gone. There, it is associated with complications, but you have less complications if you get it from a child. You can also get a transplant from an unrelated donor, um, but that's not as common. They're also getting donors from parents, for example. It's called haplotransplant, half transplant, but the parents can serve as donors uh, and to cure patients with sickle. So that's more experimental at this time. But what's more exciting on the horizon is actually we call gene therapy. Right now, we're calling it curative like, because in these situations where the patient themselves serves as their own source of cure. So what they do is they take the bone marrow of a patient, right? You don't have to take a bone marrow from another patient, and then they manipulate the stem cells of that patient. So the gene therapy, what they do is in one form of gene therapy, they take a virus called it's called the lentivirus, retrovirus, very similar to the HIV virus, but it's not the HIV virus, but it's similar in class. What they do is they take the genetic machinery of that, and they actually they modify that genetic machinery of that, and they actually um, put it into the bone marrow cells of the sickle cell patient. That's after they collected the bone marrow cells, and uh, then they take those cells and infuse it back into the patient. Okay, so and what that does, it allows, uh, and in that form, it actually inserts a gene. Okay, a hemoglobin we call it, next to the sickle cell gene, and it tells the bone marrow to make the normal hemoglobin, and the sickle cell percent goes from 80%, 90%, drop down to like 40%. So that patient becomes like a trait patient. Okay. And
Okay.
so far, that form of it's called a gene addition. That form of curative light gene therapy has been the one that's been used the most. And then that form is not without any hiccups. They've had a couple patients with either bone marrow failure, what's called myelodysplastic syndrome, or leukemia in about 50 patients so far. But so far, most majority of patients recently they've improved their process. Now it's looking more and more promising as a treatment for patients with sickle cell disease. And then the other forms, there are a whole bunch of them. Another one where they are using the CRISPR technology. I don't know if you heard of that, but I'll just make it simple. This CRISPR technology is used to clip genes and repair them, for example, right? In this particular form of gene therapy, this therapy, they take the patient's bone marrow cells, and then they treat it with the CRISPR gene. And what it does, this CRISPR technology targets a gene that shuts down that baby fetal hemoglobin. Okay, and what it does, and they give it back to the sickle cell patient. They infuse it back. Okay, and in that patient with that curative therapy, it actually drops the sickle cell percent down, but it increases the fetal hemoglobin level very, very high, like 70, 80% or so. And it makes that patient have a very, very high fetal hemoglobin level to the point where they don't have pain in the majority of cases, for example. So that is through CRISPR technology. So there are other forms of gene therapies that are being tested in the early stages. There's some that did not work, but overall, it is very, very promising for another blood condition called beta thalassemia, where you don't make enough blood cell. It's already FDA approved. This CRISPR technology to cure, and also this gene addition to study the gene therapy to actually cure the beta thalassemia patient. So right now, the FDA is reviewing gene therapy right now as a potential treatment for sickle cell disease patients. So it would not be surprising by this time next year there might be an actual gene therapy FDA approved treatment for sickle cell disease patients, which if you'd have asked me this 5 years ago, I would say no way. But we are now, the field is moving fast. Now, I will say, at this point, obviously, these therapies are very expensive. There's some who say that these are in the millions. We don't know what it will cost when it comes to the market, but that is something that we are concerned about. Um, and when you compare the lifetime cost of patients with sickle cell disease, that can be in the millions, doing the gene therapy for a certain subset of patients, not everybody would be offered this. It may have a similar trade-off in terms of the cost, not only to the patients, not only to the health insurance, but to the families and the days lost from work, quality of life. So a lot of things this could be a game changer, but also most importantly, therapeutics is coming out of the clinical trials just as important because not everybody will have access to gene therapy.
Absolutely. Well, we have just learned so much this evening about sickle cell disease in general, and also about its impact and how it affects the eyes. And so, as we're wrapping up here, I'm going to give each of you the opportunity to kind of say, what's that one thing you want people to take from this program as regards to sickle cell disease and or their how it impacts their eyes. So, Dr. Scott, we'll start with you.
Thank you. The take-home message I would like to echo is how important a good, thorough eye exam is. And sometimes we don't go to the doctor, and sometimes we don't go because we're scared. We don't want to hear what they have to say. If something's wrong, we don't want to know it, but it's really important because there are some things, if we detect them, we can treat them before they cause a problem, or we can follow them or tell you what to watch out for if things worsen. So I would like to just echo the point of getting the eye exam, a dilated eye exam, at least once a year. And this is particularly critical in individuals who have systemic diseases, yes, like diabetes, yes, like sickle cell disease, and those of us who get to be around the age of 50 or so and things start changing, and there are some age-related changes as well. So please get your dilated eye exam at least once a year, and your ophthalmologist will tell you if you need anything sooner or if there's anything they need to look out for or any treatments that you need. The other point that Dr. Campbell made is that there is a body of literature that even in the retina space that shows that hydroxyurea, the old tried and true FDA approved therapy, the first one for sickle cell disease, is actually helpful to decrease some retinopathy risk, from in the eyes. So not only is hydroxyurea helping your overall decrease, frequency of your pain crisis, but you may actually be helping your effect of the sickle cell disease, helping it from damaging the eyes as it might. So another plug for taking hydroxyurea is, I know some people are hesitant to take it for various reasons, and understandably so, but most people will say, well, whatever happens, I can't lose my sight. My sight is the most important thing to me. So hydroxyurea has been shown to be helpful for decreasing retinopathy risk.
Right. And before we go to you, Dr. Campbell, I want to let everybody know that I've been dropping some links to a variety of resources in the comments. And so whether it's about your eyes or about sickle cell, from the CDC to the management of sickle cell retinopathy, and everything in between. All those resources are hyperlinked in the comments, so you can share that with your family members. You can share that with your friends or anybody that you might know that has sickle cell disease. Dr. Campbell,
Yeah,
last thought.
Yeah, I just want to echo what Dr. Scott said. Make sure, please screen eye screening for sickle cell disease patients. It's so important. And as a pediatrician hematologist, start at age 10 and do not miss an age. And then second point is preventative measures. Again, FDA approved drugs such as hydroxyurea is already shown, as Dr. Scott said, to prevent the progression or development of the eye disease, the retinopathy that we see in sickle cell disease patients. So please see your eye doctor, or if you know someone, ask them if they've seen an eye doctor that can dilate their eyes to check the back of the eyes. Thank you.
All right. So I want to say, as we're wrapping up here, thank you all for joining us. Please check out those resources. There are a lot there. There's great information. A lot of people working very, very hard to help make your lives easier if you're dealing with sickle cell disease and retinopathies. And so there's a number of resources there. So please go check that out. I want to thank our partners at the Children's Vision Equity Alliance, as well as our partners at the National Eye Institute, for helping us put on this Seeing Eye to Eye program every month. So we're on the fourth Tuesday of every month here on BlackDoctor.org. So I want to thank them as our partners in this, helping you protect your eyes. That's why we call it Seeing Eye to Eye. So we want to make sure that you are seeing the way you should. So thank you again, and we'll see you next time.